Welcome, everyone. My name is Jack Crowe, and here is my friend Carmen David. And we are from Aortic Athletes, and we're so excited to be with you tonight to present a live chat conversation and presentation with Dr. Tim Churchill from Mass General in Boston. And tonight is a little bit of an experiment and a little bit of an innovation. About 6 months ago, Carmen and I founded a Facebook support group called Aortic Athletes, kind of a niche or a safe space where people with all kinds of aortic diseases could find good science and good recommendations about exercise. And our motto kind of became, don't quit, adapt. And in that, out of that experience, and I think we have almost 400 members now, we've begun to work with Aortic Hope, this wonderful organization that has this great platform for live chat videos. And we thought, what if we got is there a demand and interest in some of the top cardiologists who are doing research in our area? And tonight, we're just so pleased to have Dr. Tim Churchill. But before we get to him, because Carmen and I are going to do some of the questioning, I thought we should just briefly introduce ourselves. So Carmen David, who are you?
Hi, everybody. Thanks for joining us. I am Carmen David. My story actually begins in the labor and delivery ward. I was 33 years old, and about 22 hours after the delivery of my second daughter, I suffered a complicated type B acute aortic dissection. After 2 additional transfers, I finally made it to a third hospital after quite a delay in care, but they were able to put me in the OR and save my life. So here I am. I am partially stented and partially medically managed. But as you can imagine, it took quite a long time for me to recover from having delivered a child and going through the dissection and surgeries and all the trauma that ensued thereafter. So for about 2 years, I struggled quite heavily with depression and fear to exercise or do really much of anything. So exercise to me was actually a way. I came to a point where I physically and emotionally just broke and just decided I really needed to make a drastic change in my life to bring back my quality of life, and exercise was a way of doing that. And through the guidance and approvals of my cardiovascular surgeon in Dallas, Texas, I was able to start cautiously and just kind of worked my way up from walking a couple of blocks to a 5K and each and every distance in between, till I finally was able to complete a long-term goal of finishing a marathon, and actually did 2 full marathons in 6 months' time. So it was extremely exhilarating, doing something that I never thought I was going to be able to do again, and I did. And so I always encourage people to keep moving, and that we can live a long life and we can find ourselves again. So that's about all my story. But Jack, let's go ahead and hear a little bit about your story.
Well, I was a little bit older. I was twice as old. I was 60 when I dissected 2.5 years ago at 4.3 centimeters. Who knew I had 3 brothers who also have aortic disease without a genetic trait that's been identified yet. But before dissection, I had been a long-time Ironman triathlete and marathon runner and especially endurance cyclist. And so I was a pretty fit person going in. And after I dissected, I ended up having an arch that was ascending, and I had an arch replacement 6 months later at the Cleveland Clinic after the emergency. But after the first dissection, I got advice to start walking. And because I'm a literalist and maybe a little OCD, I started walking a lot. Like within a month, I was walking 5, 6, 7 miles a day. And I continued that for 2 years. So little by little by little, I built this big, low heart rate capacity. And that's led in the last 9 months to some, I wouldn't call it running, I'd call it jogging. And the net result of that is 6 months ago, in June, I did a half marathon for the first time post-dissection. Well, I didn't really run it. Like I said, it was slow, 13-minute miles. But I check my blood pressure when I'm running. Every 5 miles or so, I carry my battery cuff. I know right where I'm at. and my average heart rate when I run is probably between 100 and 110. And I know my blood pressure is, in the teens, 110 to 120 most of the time. So I'm all about the science. I'm all about exploring the wonder in this new part of my life. So we're going to get to Dr. Churchill now. And here's the caveat I have to give. He's not our doctor. He's going to talk generally about, his research and about a lot of areas we're all concerned about. And we have lots of questions to ask him. But we all know we need to go to our own doctor, make sure we're running any exercise program by our own cardiologist. And that's, that's the way we'll do it. Carmen,
Yeah.
do you want to say
Yes.
a word about Dr. Churchill, and then we'll turn it over to him?
Yes. So by way of background for Dr. Churchill, he is an instructor at Harvard Medical School. He is a cardiologist at Mass General in Boston, and he has done an extensive amount of research focused on athletes with cardiovascular disease, including the aorta. So he is going to give us an update on that research, and Jack and I will be able to ask some questions that like he said, most of you have provided some questions, and then we'll have some time for some live questions as well. So without further ado, please welcome Dr. Tim Churchill.
All right. Well, thank you guys. Thank you guys very much for asking me to join you here. And thanks to Jack and Carmen for organizing this, and thanks to everyone watching. I'm just going to share my screen right here. And as these guys mentioned, I'm going to be talking for a few minutes about some background, some research that I've done as well as others, and then we'll open the floor for some questions. So just to check, are you guys seeing the presenter mode?
Yeah, correctly? Looks good.
All right, so I'm going to talking today about athletes and the aorta, and really exercise in the aorta in general. And I will say I come at this from the lens of a cardiologist who has had a primary and long interest in studying the way that exercise and athletic training affect the heart and the cardiovascular system more broadly. So that's kind of the framework that I've brought to this topic and this area of research. So not news to anybody here, but it's always important for me to start out with the why, which is to say, why do we care? Why are we talking about this? And so obviously aortic size is the biggest risk factor for all of the different forms of acute aortic syndromes. That's a known fact. That's not going to be a surprise to anybody here. My background, as I said, is looking at and thinking about the heart and how it adapts to exercise. So this is something that we in our field have looked at for over the past, really over the past couple decades, but actually dating back to the late 1800s, where researchers have shown that the heart adapts to the pressure and the volume loading of the different stimuli of chronic exercise, and it adapts and changes in different ways. And so this led within my research group to the question of, as well as others, to the question of whether the same forces from exercise lead to accelerated change and growth in the size of the aorta. So the background that I always come back to, I like to sort of think of myself as both a physician and a physiologist. And so I think the background I always try to come back to is the grounding and the physiology of exercise. So what happens with exercise? I think this exactly dovetails with Jack's comments just a moment ago, which is that exercise is really characterized by a sustained increase in what's called the cardiac output, which is the amount of blood that your heart is pumping, and the blood pressure. That is a broad term, but then when we break it down a little bit, we differentiate between different sports that are more aerobic or endurance focused versus more strength focused, and then some that obviously have a combination of the two. So when we look across this bifurcation, we look at the way that these impact and the way that these challenge or load the cardiovascular system. So marathon running, for instance, would be the paradigm in this case of a volume challenge, where it's basically the heart is pumping a lot. Blood pressure goes up, but not dramatically so. Contrast that with the weightlifter that we see here, or a lineman on a football team, and these strength kind of more static or burst type sports, whereas where we see the fundamental challenge being these repetitive spikes in blood pressure. So and then obviously that is a simple sort of schematic across where we're defining things based on one of two things, but the reality is that a lot of sports really combine both types of physiology. And so this is a schematic that's been developed and kind of has formed an important framework for our field, where different sports have been classified based on the degree of the dynamic component, which is how you can think of the intensity of the aerobic component versus the static component or the strength component. So something like weightlifting would be up in the upper left corner, whereas something like marathon running would be in the bottom right corner. Sports that really combine, the sport that I think of as kind of the paradigm for combining the two is rowing or crew, but other things like cycling or anything that really also includes both significant increases in the amount of the cardiac output, the amount that the heart's pumping, as well as the either repetitive or sustained increases in blood pressure. So we use this paradigm to understand how the heart adapts. I'm just going to talk briefly about this to lead into thinking about the aorta, which is that these two basic exercise type physiologies have been shown and well shown in many studies over multiple decades now to really associate in two different kind of paradigms of cardiac adaptation, or what we call exercise-induced cardiac remodeling. And so basically, so the way we sort of boil this down is that with the volume stimulus, we see the heart enlarge or dilate, as well as thicken to a varying degree, as opposed to the strength training where and a pressure stimulus, where the heart muscle thickens, but the chamber size stays relatively the same size. So translating this is turning from here to the aorta. I always start with that exercise physiology because that really frames how the clinical concerns about exercise and the aorta and how we think about how the exercise may impact the aorta. So anybody who's been through any kind of acute presentation or more chronic related to aortic disease will know that the thing that the doctors are worried about are your heart rate and your blood pressure. So obviously that dovetails very closely with exercise, because in that those are really the two dominant aspects of the way of the underlying physiology of exercise. So it stands to reason, and this is kind of the undercurrent that has sort of driven a lot of the research in this area, that it would stand to reason that a lot of the same hemodynamic or sort of blood pressure and heart rate related forces that impact the heart in the ways that we were just describing could also impact the aorta. So before we get into turn, I'm going to focus a lot of this on more middle-aged or beyond athletes, but I think it's important to start with the data on aortic enlargement in younger athletes, as this is really where the vast majority of the research in this area has come from. And until a couple of years ago, this was actually really all there was. So most of the data here have come from large studies examining young athletes in a handful of different countries around the world, mostly in Europe, that have had large screening programs for all their elite athletes. And what these have really universally shown is that large aortas, and this has been defined variably, but mostly 40 millimeters and above in men, often, and then varying like 34, 36, 38 in young women. Large aortas are rare in young athletes. And so this was data from the Italians. It was published almost 15 years ago, where they showed that the 40 and above represented the 99th percentile in their group. Similar story in the Spanish data, the British data, and the Japanese data. So really, this is one of the things that's been really, I would say, really quite firmly established. This comes up every now and again in my work, where we meet a young athlete who's a college student somewhere who's found to have a big aorta, and there it becomes a very clear, unambiguous question, which is that a significantly enlarged aorta in a young athlete is both rare and is therefore ergo is not abnormal and would not get lumped in with what we would consider an adaptation to exercise. Same thing has been found that one of my colleagues, Paul Thompson, did a meta-analysis trying to combine all these data and found similar findings overall. Although interestingly, they did find what we would term kind of a small signal that overall the measured aortic dimensions in the athlete groups when compared to controls were a little bit larger. So it sort of raises the question of, is there something about sports? There's also a lot of, these are not, by no means, none of these are perfect studies. There's always confounders or sort of challenges in measurement, but raises an interesting question. I think that's kind of been the spark of some additional research that I'll talk about in a moment. But the important takeaway here in the young athlete population, so this, which as I was saying, certainly comes up from time to time, significant enlargement is pathology, and it's a genetic abnormality until proven otherwise, or something that we look for, and needs to be managed accordingly. So similar data, there's obviously a relationship of aortic size with body size. So similar data has come from looking at populations of very large athletes, so professional basketball players, similar, slightly more bigger aortas, but still the prevalence of significant enlargement is really quite rare. Same with professional football players. We've also seen this with professional female basketball players. So similar story. There's a slight enrichment because there is this relationship with body size, but it seems to plateau, and the findings still hold that significant enlargement in the young athlete is both rare and therefore we consider it pathologic, not adaptive or not a form of remodeling. So that's the data on prevalence in the young athlete. So there's been a few studies looking at the question of what happens if athletes continue to train, continue to complete. And this is much more, whereas before we were talking about a handful of studies with 2,000 people each, this is now we're getting into 10, 15, 20 people. So much more limited data, and it's much harder to make any kind of meaningful conclusion from this. So this was a study, again, this is from the Italians, where they showed that in a group of 17 individuals who were kind of followed sequentially for an average of 8 years, they did see an increase in the average size of the average aortic size among these individuals. This was primarily driven by a couple individuals who grew significantly, whereas there were a handful that didn't really meaningfully grow much at all. Similar, I would say, are similar findings from the British group, where they looked at the similar things, but in this case, they didn't really see that the individuals growing markedly, and so they showed, on the whole, among the small number of people who continued to compete with a known finding of aortic dilation, they showed overall stability over the span of about 5 years, with some small changes there. So this is really where we were left a couple years ago, and we were left with this knowledge gap, and this came up. And also, this came up both. This was of interest to us scientifically as well as clinically. This is something that we were seeing in my clinical practice, which is centered on what we call sports cardiology. We're working with athletes or people for whom exercise is an important part of their life, with all forms of cardiovascular disease. And we were frequently seeing folks who were found to have an enlarged aorta. And so this question has come up: how do exercise and sport continue to impact the aorta beyond this early stage of life, where these elite athletes in their teens and 20s? So as I mentioned, we had observed this, and we had seen this was not a rare thing for people to come in with an aorta that was 42, 43, 44 millimeters, that was found incidentally when they got an echocardiogram or a CAT scan for some other reason. And so this led to the question of how much of this, is there an impact of this? Could this be related to all of these long-term, this exposure to long-term exercise, this exposure to long-term increases in heart rate and blood pressure? Could this have an impact in a relationship with the aorta? So this led to a study that we did a couple of years ago now, which we're at present kind of building out and try to build out the follow-up to this, but looking at a group of athletes, and we focused on an endurance athlete with a group of runners and a group of rowers, and these were really quite accomplished individuals. And with I think among the marathon group, I think there was something like the median was an average well over 20 marathons completed over the course of their lifetime, with a bunch of people who having completed over 100. These were former world champion rowers, former Olympians. So this was people for whom sport and exercise and training had been a big part of their life for 20, 30, even 40 years. And so we looked at these, and we we enrolled them in a series of different events across the country, and then tried to study them without any a priori selection, and tried to study them taking echocardiograms of their heart. So what did we see? We saw, number one, we saw what I would describe as a relative enrichment of relatively large aortic sizes. So you can see here, this is in the top, this is men, bottom in women, measuring at different points in the aorta and highlighting the number, that relative prevalence of folks with aortic measurements that were in what we would typically term the enlarged range. So in this case, using a cutoff of 40 men, or in some cases for women using a smaller one, as kind of replicating the prior literature. We also tried to look at this, again, this is sort of one of the fundamental challenges with this area, is that this is something that is really hard to study because you can't randomize someone to exercise for 3 decades or to be sedentary for 3 decades. So what we try to do is we try to get inference as to how does this compare to the population or to these otherwise age, sex, and body size predicted norms. And so this is what we plotted here, which is in the kind of the paler gray was their actual measured size versus the darker gray was the predicted size based on the existing best kind of guideline endorsed nomograms. And we see again a clear enrichment for bigger than expected aortas in this case. So this led to the hypothesis, and so I'd say provided fuel for this hypothesis, that there may be some element where the chronic exposure to long-term endurance exercise may be a contributor to enlargement, and certainly not to say that anything is proven or anything is definitively established, but that was kind of one of the takeaways from our initial study there, in which we're looking to study a little bit more over the next couple of years. Similar, very different population, but this was a study looking at former professional American football players. You can see on the left here, this was their measurements. This was done using CAT scan, but showing a really marked, almost 30% of them had an aortic measurement that was greater than 40 millimeters. They did their best, their attempt to compare it to a population was from a different study that was sort of similar in makeup. And that group had 9%. So again, this is correlation, does not equate to causation, which is sort of one of the tenets of medical research, but certainly these data are suggestive and make you think that there may be a relationship here. Similar findings. This is a study from Australia looking at rugby players, slightly younger group, but again, they took the same approach of trying to compare them to a set of a control population, and we see what I describe as a rightward shift of the distribution of the rugby players versus the controls. They also saw some findings of some greater frequency of what we would call abnormal architecture, or the way that the different parts of the sort of anatomic relationship of the different parts of the aorta looked between the different. So again, suggesting that there may be a plausible relationship or mechanism between these long-term sport participation and changes in the aorta. Difficult to say anything with certainty, but this is kind of in these areas that are difficult to study. This is the way that sort of we try to build up different data that can be orthogonal or can help build a complete picture for us. So just a couple more words. This is thinking about just to highlight some recent data came up from some of my colleagues down at Emory, where they were trying to look at and explore what might underlie this response. How might this be happening? So what they explored was they looked at a series of male runners in their 50s and beyond, and imaged their aortas and found a handful, kind of again about 20% with a aortic measurement greater than 40 millimeters. And then they looked at this and they did exercise tests and tried to compare them with, tried to look at this as to how much the blood pressure went up with exercise. So again, harkening back to Jack's comment, and went up to, and they found that the larger aortic size was associated with a greater, in adjusted model, greater blood pressure response to exercise. So again, it makes sense intuitively when trying to provide evidence to help try to explain what may happen over decades and trying to think about how the aorta may respond to exercise overall. So I think this leads to the question of, is it an aorta? Is this the same? We think of the heart adaptation, the cardiac remodeling that I talked about before, as a benign thing, and that we think it's different than a enlargement of the heart that might be related to some form of heart disease. We think of this as a very different thing. So does the same thing hold if exercise is maybe associated with any of these responses to any of these changes in aortic size over time? What are the implications of that? And that's really the open-ended question that's I think, gonna be the focus of study for the field for the next decade or more. So this is where I try to turn towards how does the exercise impact the physiology? And this was a very interesting study from a couple of years ago from the UK, where they looked at people training for their first marathon, and they looked at how distensible the aorta was. And this was one way of measuring what we think of as potential one metric of aortic health. It's not the only thing, but we generally think more distensible equals healthier tissue. And so what they found was that when they looked at people before and after training, they saw both improvements in blood pressure, which is another obviously important impact from exercise training, as well as improvements in distensibility. And this was most prominent in the individuals who were older and also who were less distensible or more impaired at baseline. So same question, which is really, I think that kind of gives us some information that there's certainly good things that are happening related from exercise, but what is the net or the ultimate takeaway? And I think this is an area where we don't know, where we like to rely on data, and we don't really have any good data here. So this is the extent of the data about aortic dissections in the context of exercise. This was a study where they looked at a series from one institution, a handful, almost 500 dissections, and they found that about 5% had occurred in the context of sport and exercise. And interestingly, this is sort of one of my favorite trivia comments, that the most common sport associated with this was actually golf. But then this is a good lesson in terms of you don't want to necessarily impose too much causality here, because I think that's probably mostly driven by the population that's playing golf versus the population that's doing other sports. Exercise, what about exercise after aortic surgery? Similar story in that we don't have much in the way of data. This is really about it, which is a paper that was released just about a year ago, and where they looked at individuals who had a bicuspid valve and then had surgery and then came back to exercise, and they showed that they were able, for the most part, to do so without any real recurrent events. The only issues that they kind of encountered afterward were related to the valve and not to the aorta itself. So again, these are areas where this is really very individualized without any clear and definitive takeaways based on the data. And so we're left working with people individually and trying to make the best assessment that we can. So I think I'm going to just kind of close and momentarily by talking about this is what our recent guidelines that were released, the physician guidelines that were released related to aortic disease a year ago by one of my colleagues in the writing group. And this, I think I show this mostly to highlight the item at the bottom here, which is that there is really a growing consensus that there is a real role for exercise. And this is specifically in this case talking about individuals with aortic disease who haven't had any clinical events, but there is a real role of exercise, both from a quality of life standpoint, from an overall cardiovascular health standpoint, and from a blood pressure standpoint, because we know this is also beneficial in each of these axes. So these are kind of my big takeaways here, which is that exercise, the impact on the aorta is plausible but remains unproven. In the young athlete, aortic dilation, significant aortic enlargement is rare, but this seems in the middle-aged or the older athlete, this seems like a slightly different picture, in that certainly in the mild to moderate enlargement is certainly seems enriched and is more common. But what do we make of this? What does this mean, and what do we do with this are still really uncertain in areas of active investigation. So this is what I do when I meet someone and talk about these things. We come up with a plan for monitoring. We look for any features that might suggest high risk. We work on blood pressure as well as other risk factors. We'll often look at what their blood pressure does with exercise, and then we have a conversation, a joint decision-making process about what makes the most sense for them. Because I think, as you heard earlier from Jack and Carmen, I think the role of exercise and the benefits of this in helping people reclaim their life are really not to be underestimated. So I'm never sitting down and telling anybody, oh, this is definitively, you forbidden, you can't do this. It's a conversation and it's a joint decision-making process. So lastly, just to kind of close, this is kind of the future. I think that things that we're working on are both kind of trying to actually pin down the implications, trying to correlate, think about the mechanism and the why, and then trying to differentiate this question of, is this adaptation or physiology that we've kind of observed versus is this a manifestation of pathology, and what are the implications of that? So I will stop there. Thank you everyone for listening, and I will stop sharing this, and I'll happily chat and answer any questions.
Wow, thank you so much, Dr. Churchill. That was terrific, and it's. I wish we had a more definitive answer, but that's where we're at.
It would make my life easier, that's for sure.
It seems like there's sort of a culture shift among cardiologists on the recommendation of exercise. It seems like the old advice used to be, I once heard it said, don't lift anything heavier than a fork, which was probably not good advice, led to people becoming depressed or giving up and thinking their life is over, which is a real issue that many people who are diagnosed with aortic disease feel. It's like, so it's over, game over for me, right? So could you describe, for the average cardiologist out there, how would you change their mind on that?
Yeah, I mean, I think what you're getting at is very true, in that there has been I would say there's a culture shift in this area, specifically in aortic disease. There's a culture shift in, I would say, the overall field, and I would say even just the recognition of the idea that the field that we call sports cardiology, that the recognition that this is an important kind of subfield within cardiology, and there's a culture shift I would say just in general about I think there's a growing recognition of the myriad benefits of exercise, and I'll sort of lump those into the physiologic, the cardiovascular, and the kind of health promoting, as well as the mental health and the quality of life and well-being side to things. And those are really both, in my mind, kind of equally important. And having seen the downsides in varied contexts, and I work a lot with young athletes with different forms of heart disease, but it's the downsides of when people have been restricted, when have their lifeline, their exercise, whatever it is, cut off from them. So I think that's one element in terms of a really changing paradigm. I think another important part of that is that there has been I'll say a sort of slow but growing sort of body of literature looking at the safety of this. And I think it's because this is something that we like to, we really do like to try to pride ourselves on being a scientific and evidence-based field. And so, yeah, I don't want to be I believe deeply in exercise, but I also don't want to be the cowboy out there saying, hey, go do this and that and everything's going to be fine, because obviously there's times when it's not. And so, we try to, I think part of the onus is on us to continue pushing into developing the evidence basis in order to get it out there. And then, I think as to the question about how to spread the word, I think it's a slow process. It requires as I said, kind of building out the evidence. It requires, I think, the more that these things can make their way into the guidelines that we all turn to when we have a kind of a challenge, when we're not totally sure what to do with the patient, the better. So I think all of those, it's just, and then the last thing I think is really just that there's a growing push towards educational programs, kind of peer educational programs among physicians and cardiologists, we have, for instance, we have within the American College of Cardiology, we have a really robust sports and exercise council where we try to work and develop educational content along those lines. So I think those are all the real kind of the ways it can happen, but it's definitely a slow road. And I think the last comment I'll make there is I think with that, in parallel with that, the other really important paradigm shift has been this idea of we use the term shared decision making, as opposed to kind of the physician in the white coat sitting up on their chair going, and it's, and that's really one that's evolved in a lot of different areas across medicine, not just cardiology, medicine in general, but in the field of exercise and sports, really specifically around different questions of athletic, we'll say sort of eligibility or recommendations. And it's really taken the idea of really placing a really important value on patient autonomy and patient values and what's really important to them, and trying to make it instead of a binary yes, no, make it much more of a joint decision-making process between, and ideally I'd like to do these things. It's not just the patient, it's their mom, it's their parents, it's their kids, it's them, other physicians, et cetera. So it doesn't make it, it certainly makes the process, in a way, it's more difficult, but I think it's much more meaningful to try to engage people with the decision-making process. So I think that's the other paradigm shift that's been an important part of this. And that's also, I'll say, sort of a slow spreading thing, but it's definitely been a big change over the last 10, 20, 30 years.
And then if you put on look at the crystal ball and are looking out 5, 10 years from now, do you think we'll get to the point where there will be general guidelines? Some of us are participating in the post-aortic dissection exercise study out of the University of Texas, and we're active participants. And one question is our individual experience of aortic disease so unique that there never will be kind of a standard guideline for anyone?
Yeah, it's a great question, and I think this is sort of a fundamental challenge that comes up in anything kind of like this field, which is one of the things I was getting at before, which is this is really fundamentally hard to study, which is that we like in most of, in a lot of cardiology, we like to just develop these 10,000 person blinded randomized clinical trials where we give people a placebo or a drug, and then we look what happens to them. And you can't do that with something like this. You can't do that with extra, and to be honest, you can't really, you can't sort of randomize someone to an exercise program or not. So I think it's going to be as a result, it's a much slower process to develop the kind of data that will be enough to substantiate recommendations in the guidelines. And we think, and we'll probably never get what are termed really the class 1 guidelines, which are the ones that have really the highest level of evidence. But I think it's studies like the one you mentioned, it's studies like the one that I'm trying to sort of do as a follow-up. It's studies like the sort of what we have in the works for the coming years in terms of trying to develop broader, longer term longitudinal things to sort of follow and look for people who may have whether people are having dissections in the context of exercise and things like this to really develop things. So I think it's going to be a much slower process than we all would like because of the challenge of studying this. But I think it is something that it has gotten into the guidelines here. It's gotten into the guidelines in other forms of heart disease, and I think that's a clear march forward. Because I think the field more than 20 years ago recognizes, number one, how important exercise is to people, and then number two, how important exercise is to cardiovascular health in general. And so we'd be negligent as a field if we fail to address this, then that's on us. So we obviously want the engaged community supporting it and helping push the needle. But it's I think it is a really important and essential ingredient for kind of taking good care of this population.
And I think everyone on the call, I know, appreciates the collaborative process, being a part of the decision making. Carmen, what questions do you have?
We have a lot of questions. Well, one I was going to say, so you spoke of, pardon me while I'm looking down a little bit because I'm reading some notes that I took during your presentation, but you spoke about it being rare in the younger athletes. And what ages were you specifically talking about? Because you did mention about the teens up through, greater, up to about 40 were in the rare field. So a lot of our athletes, not all of them, but a lot of them are probably in that area of the 30s and 40s. And there are some cases of those who are in their teens playing certain sports or wanting to do these higher endurance activities. So when you also mentioned about it being more pathogenic in younger athletes, is that something that your guidance would differ in the recommendation of what they should and shouldn't be doing, just based on, even if they're in that rare category?
Yeah, so I think at the extremes, so I'll comment on what the data have shown us, there were these handful of studies and they have different age criteria or cutoffs, but mostly they were late teens into 20s with some. So that's kind of the bulk of what I kind of term the young athlete data has come from, and that was the group in where it was sort of very, very clear that there was not a significant enrichment for big aortas. And so I think in that population we were left with the conclusion that there's certainly a higher likelihood of either an identifiable genetic cause, or there's also certainly kind of cases where we think there may be a genetic driver, but there may not be a specific gene that is found on commercially available genetic testing. So in those circumstances, I do certainly, I do certainly have probably a greater note of caution than in the, if someone has a given aortic size in an 18-year-old is a very different thing than in a 55-year-old for me, mostly because I think it implies a greater likelihood of an underlying cause, an underlying genetic or other type of cause, which often imply that the aortic wall strength may be more compromised, and that there may be more risk of dissection or other things. So that's the big takeaway. And I think the other takeaway is, I think you have to keep in, when you're sitting down with an 18-year-old athlete in clinic, it's always a different conversation than it is with a 38-year-old with 3 young kids at home. And that they're at a very different place in life. What their exercise, their sport, or whatever it is means to them is also different. And so I think that's where an important part of the whole equation is getting, sort of meeting them where they are and getting to know them and what their values are. So yeah, the medical part is one thing, and then the personal part is also, I would say, different in the 19 or 22-year-old than it is in the 55 or 60-year-old.
Okay. So then as far as like recommendations and restrictions, because I know there, like you said, there's no concrete evidence out there right now of or guidance on what to do, but do you, in your cases, follow different recommendations and restrictions based on case type, whether it's a bicuspid aortic valve, whether it's repaired or unrepaired, if they have like a leaky valve or stenosis or regurgitation, all the different types, type B, type A, just a watch and wait. Do you approach those differently, or just still like a general guideline or by case basis?
Yeah, I think it's always a case by case basis with some unifying principles. I think, that you always, things that you're always thinking about are, and I think the comments about blood pressure that Jack had made about blood pressure, the comments, you always think about things, the very high risk, sports with a lot of potential for significant contact always sort of raise the possibility of a different issue, where like the football, hockey, and other rugby, things like that. And then beyond that, I think there's just a lot of nuance in what in the particular circumstance of, as you said, does someone have a bicuspid valve with severe aortic regurgitation, or do they have a totally competent valve? And this also, when someone gets in the neighborhood of where you're talking about and thinking about surgery, then the particulars of the case also impact what type of surgery might it be, what the risk profile of how complex is the surgery, what and so all of those things, I would say, sort of ultimately play in. And so there really is not, I think, particularly in the context of trying to also think about things in the athletic context, there's no real one size fits all.
Yeah. So I guess you can't give an answer to people who want to play rugby and ice hockey and do jujitsu and boxing, like anything that's like more high impact. We do have people asking those types of questions specific to those higher impact exercises.
I think it's always, there really is no, without knowing any of the particulars of things, it's always I always sort of hesitate to those things certainly will, if you meet two people and one, if you had identical twins with the same aorta, and one says they want to be a competitive pistol shooter and the other wants to be a competitive ice hockey player, that's certainly, that's a different conversation, just because the physiology of the sport is different, as well as also the possibility for contact and what we term deceleration injuries is different. I mean, I think the other, I'll say the other kind of underlying commonality between these things that I'll say is, one of the, I'll say sort of the important things, this holds true in my field across a lot of different cardiovascular conditions, is we try to separate out the questions about athletic eligibility or risk from the questions about should this person have surgery, for instance. So we're not typically saying, oh, we should fix your aorta so you can go back and play, or something like that. Those in my mind are two completely separate questions. We decide when it makes sense to intervene on an aorta or to place a defibrillator for other cardiovascular conditions, and then we separately have a conversation about what is the risk profile as it relates to the possibility of either exercise training and or competitive sport participation. But that's kind of an important thing that comes up a lot, because people, particularly when people come for whom their sport, their exercise is a very important part of their life, they say, hey, can't we just fix this and I can go back? And I try to make it very clear those are separate questions.
Yeah, and it's not that simple.
Yeah.
Yeah. Jack, do you have any other questions that you might want to ask?
Oh, Jack, we need to unmute you, Jack.
There we are. I was going to ask our colleague Joshua how we're doing on time, and do we have any questions from the field?
We do definitely have some questions in the field here. You guys ready to hear from Chat?
Yeah. How much longer do we have till top of the hour?
We're at about 11 minutes till the top of the hour.
Oh, okay. Let's hear some questions from people who tuned in.
Okay. Let's go ahead and start from the top of the roll there. Hi, Velda. Hi, Larry. Thank you for coming. And then we have our first question coming in from John Brenny. Are they looking for participants for any current or upcoming studies?
Well, that's a great question. I appreciate it. We at the moment, what we are working on is actually a follow-up from my the one I kind of mentioned earlier. So for that it's a re-enrollment from individuals who had been our original one. I think we have kind of plans in the future, and so I think there may be, I think if there's a pathway maybe for people to kind of maybe we can, Jack and Carmen and I can offline can kind of think about if there's a way for people to reach out to express interest, even just to kind of put their names and emails down. That would certainly be wonderful, because I think we do have ambitions of a sort of more longer term decentralized longitudinal sort of registry type study. But those types of things, it's actually the infrastructure is it's a big lift to get things set up and rolling. But I think if there's a way for capture if people have an interest, I'm certainly delighted to hear that.
Okay, that's wonderful to hear. Hi, Tam Tam. I forgot to say hi to Tam Tam. Catherine Dono says, thanks so much for doing this. Bill Schmidt says, I don't have a question. I'm following my cardio's advice and have done research on my own, and I'm comfortable with what I'm doing. Thank you for putting this together for all of us. And then we have our question. Let me make sure I've got this right. This is coming in from Larry. Is elevation a concern? I'm 66 with type A dissection surgery 6 months ago. Went to Lake Tahoe at 7,000 feet for vacation, easy and moderate hiking. Noticed rest BP went up by about 10 mmHg.
Yeah, so elevation does a lot of things. Obviously, elevation can the main underlying difference obviously is that the partial pressure of the level of oxygen that you're breathing in. But with that, we can often see changes in blood pressure, as you mentioned. We can also see just changes in the demands that are on the cardiovascular system. So I would say in general, what I talk to people about is sort of whatever level that you're doing at sea level or similar, just to kind of take it at least until you're acclimatized, take it down a little, or just take it relatively slightly easier. And then the other things that I think are sort of common sense things, but the basics are of hydration, respecting the kind of the impact that what alcohol can take out of you at elevation, and then really just listening to your body. If your body needs to sort of back off, then that's the main thing. And then I think the last comment about elevation really is that the single most important thing with elevation, because anybody can, regardless of aortic disease or not, can be susceptible to different altitude related sickness, so things like acute mountain sickness or high altitude pulmonary edema or cerebral edema. And so to the extent possible, acclimatization, when people are of trying to slow the to ascend slowly, if hiking or trekking in any form, and or I think if and when people do experience any ill effects, the most important thing is to get down to lower elevation. So those are kind of the basics of high altitude medicine, and so I think the basics would be the things I would highlight here, and just really making sure not overdoing it, and listening to your body, and if it feels like it needs a little bit, dialing it back if it feels like it's necessary.
I'm heading to the Pyrenees tomorrow to hike, so I'll keep all that very much in mind.
Great. Well, you'll have a great time, I'm sure.
Hey, another question that always comes up is about weights. And both, I'm going to say it in two contexts. Weightlifting, of course, we have a lot of weightlifters, and people want to kind of push, and everyone wants a clear red line of how much is too much and that stuff. That's one side of it. The other side is a lot, particularly post-surgery, but even people in watch and wait, oftentimes get doctors saying, thou shalt not lift more than, and then the number will be 20 pounds or 30 pounds or 50 pounds or whatever. And I can tell you personally, nothing causes more stress in a family relationship than, you go to pick up a bag of groceries and, whoever you're with says, oh, you don't lift that. So could you talk for 1 second about weights?
Yeah, so I will, I'll say with the same caveat, which is that this is really the data, the ultimate kind of data-free zone. But I'll start with a big picture comment, which is, and this is true in other areas as well, but the strict X number of pound limitation never made a huge amount of sense to me as a framework for helping guide people, because 20 pounds for me is different than 20 pounds for Jack, and different than 20 pounds for Carmen. And so that is, I think, the framework, thinking about things in terms of sort of relative effort, I think is a much more meaningful framework, because I have patients for whom they could pick up a 50-pound thing with one finger and not exert themselves at all, and probably not cause any meaningful increase in their blood pressure. Because at the end of the day, what we care about, and the reason that we do, the physicians and the medical community do worry about this, and sort of the main driver of our concern is what happens with central aortic blood pressure, which is the blood pressure that the aorta and the ascending aorta sees. What happens with central aortic blood pressure with whatever one is doing? So in that case, and a lot of that comes from these interesting studies that were done back in the 70s and 80s or so, where they put catheters into people and had them do leg presses, and they saw that their blood pressure would go up to 400 or 300 or 400 millimeters of mercury. And that, I'm not off to tell anybody here that that's not something that really makes any cardiologist or any patient with aortic disease feel very comfortable. So that's the basis for, I think if there's one clear and consistent recommendation, is that very heavy, very, very intense, what we call isometric or static exercise. So the paradigm would be someone going to the gym and putting a squat bar on their shoulders and loading it up to max out. That's the kind of thing that I would and do tend to steer people away from, because that's the physiology. I think that's sort of, if you were to design something that would potentially be problematic for the aorta, I think that would be kind of how I would do it. The other, what's the role? I think much more controversial, and that part is not controversial, but much more challenging, is what's the role of kind of what I would term sort of mild to moderate, higher repetition type strength-based training. And I think that's a really open book, and that's not one that's one of those that I try to take on a case-by-case basis, because I think that there is an important health component to that. I always steer people away or counsel people to avoid what's called the Valsalva maneuver, which is where people are bearing down against a closed throat, or essentially when they're kind of, if you think of the weightlifter who's grunting through a heavy lift, or that can actually, what happens there is that the physiology of that is it actually causes the relative blood pressure that your aorta sees, so the difference between inside and outside, to be greater. So that's why we counsel people away from that, and counsel people towards, if they're in a situation where they are doing any type of lifting, that they try to make sure they're breathing through it, as a way to specifically mitigate that aspect of it. And so that's kind of the framework that I talk to about people about lifting in general. And I think I think ultimately that's a personal one. That's one that I would say I've arrived at different paradigms with different individuals when I've kind of gone over this in the clinical setting with them. But it's certainly I think the one clear and consistent thing is sort of the very heavy 1 rep max type of thing is something that we all get concerned. We would all get concerned about, specifically for the very high spike in blood pressure that we know that it can cause.
Okay, thank you, doctor. I have a couple more here in the chat. Tammy says, can you talk about how a dissection impacts endurance post-surgery? Does the size of a false lumen anywhere along the aorta impact endurance? My endurance is definitely not the same. Type A repair. So
that's a great question, and I don't want to sort of fall back too much on the every case is different, but I think this is one where I think the particulars of the case will be would be the kind of the key to think about answering that. There are scenarios where I could imagine where you can come up with things where it could impact kind of both the blood pressure dynamics with exercise, as well as the kind of how the cardiovascular system might respond. I think probably, on the whole, I can come up with scenarios like that, but I think more likely than anything is that the sheer amount of what the body has been through, and that is the kind of from the event, the surgery, and the recovery, kind of really are the kind of things when I meet people, I tell them to expect that it takes years to recover, and then that's under kind of, and to get back to the same, depending on where one was starting, to get back to the same place can be, can really be, in some cases, really very, very difficult, depending on the circumstance. If someone was doing a lot of high-level training, they may not feel comfortable, or their physicians may not feel comfortable doing so. So that, to me, in my mind, would be kind of the more likely impediment towards towards reclaiming the prior levels of endurance, as opposed to whether there's a specific physiology related to to residual dissection flap and/or a graft there. Although, again, I want to be that it's certainly possible, and I can imagine scenarios, but it would be very much a kind of thinking on a case-by-case basis.
Okay, thank you. And then I have another one here. Is there a good way to measure exercise blood pressure, hiking, jogging, dancing, for example?
So, I would say in general, I don't have a huge amount of faith in the use of automated cuffs in the context when someone is actively in the middle of, sort of in the midst of exercise. And ideally, you really do want to measure it as close, either during or as close to exertion as possible. So the way, in my mind, I think what I think of as the gold standard is actually during a form of a maximal effort exercise test, where a separate trained person is actually measuring it with a manual blood pressure cuff and with the good old-fashioned way with listening. The automated cuffs, I think if someone has if you kind of got a system down, it's plausible, and it may work. But I think the hard part is you really do need to kind of have your arm straightened and arm properly positioned. So I think as a general rule, I don't put a huge, it's not something that I'm specifically guiding patients towards doing that, but I think there are, when people have worked out a system, certainly, it's not to say it can't work. I just think it's the complexities of it, and you want to be sure you're getting and relying on good quality data. So that's one that I typically have people do, where they kind of, in our exercise lab, as part of kind of a consultation, but as opposed to kind of trying to self-measure, at least initially. If you're then trying to do so on a monitor sequentially from there, there may be viable ways to do so independently. But I think in this sort of the initial assessment, it should be with full effort, maximal exercise, and it should be, and I typically will think it should be done by a trained person listening to it.
Okay. I have one question to follow up with that. What would that request be if they wanted to schedule something with their physician?
Well, so I'm sorry, I couldn't hear that.
I'm asking what the community would ask for their physician. Well, what's that testing?
So I think any form of exercise test,
okay,
would be, and there's different, depending on the place and the location, there's different flavors of that. But I think that would be the sort of the broad category.
Okay, good to hear. All right, Jack, do you want to come back in?
Oh, sorry, can I cut in real quick? Something along those lines that Josh was just reading out. So is there a specific measurement that people can just look at, and if they're doing that systematically, routinely, and figured out a way to read it as best they can with an automated machine, what is a number that they don't want to see? Like, what do you not want them to exceed that they would know, okay, I need to slow down the next time?
Yeah, I think that's a hard one to answer. Again, without I don't want to sound too much like a broken record, but because it is, I'll say it is normal physiology for the blood pressure to go up during exercise, but I would say the particulars of sort of what is too much and how high is too much, I think are hard. Things that I think about and trying to integrate into when I think about that question are, what's someone's underlying pathology? So does someone have Loeys-Dietz syndrome and had a dissection and they have residual dilation, or do they have a bicuspid valve and the disease segment was replaced and the rest of the aorta looks totally normal? So those are different things in my mind, and I would be sort of more permissive in one versus in the other. So I think certainly when people are getting up into the, I would say if people are getting up into the 200s, that's where I would, which happens pretty routinely with, I'll say sort of regular, in the regular exercise population.
Like a hypertensive response.
Yeah, I think that's certainly, I would say, like, if I were to give one thing where I would say, hey, that's something where I would stop and pause, then, but I think beyond that, it's very much a real individual case-by-case basis.
Okay, thank you. Jack?
Well, I think we're at time. And Dr. Churchill, this has been really enlightening, and we are so grateful to you for your patience with our questions, but also for the work you're doing. We're the beneficiaries, honestly, and we call ourselves pioneers. We're sort of stumbling around in the dark a little bit, and we really appreciate the light that you're shining, and we encourage you to keep doing that, and know that we're here. We're here to help too. We're joiners. So if you need folks, I'm sure we can round up a couple if you want to do some fun studies.
Well, I appreciate that. I appreciate you guys having me and all the engagement and questions. And I think the last thing I'll say is, I think as a physician interested in this area, this intersection, I think it's always encouraging, and it makes the things seem meaningful when you meet these engaged communities of people. So I applaud what you guys are all doing, and how you guys have sort of turned these challenges into an important and positive role in your lives.
Good. Carmen, you want to close us out?
Oh, we have one last question. Do we have time for one last question?
Sure.
Let's. Go ahead.
Okay. Does your study include anything about the psychological, emotional response, anxiety, and fear of survivors returning to their previous exercise routine?
So we did not. So again, my specific study is actually people who haven't had necessarily a diagnosis of, or certainly any clinical events. But I think that gets at what I think one of the core things that I think when I think in the 5-10 year vision that I'm hoping to try to get at, which is to try to think about these really the multifaceted way that this impacts people's lives, and from the physical to the mental health, emotional side. And so that's something we have been doing work with a large registry looking at young athletes with various heart disease, and that's one of the central areas of focus where we have been trying to think about how people respond to this diagnosis, how they process it, how they deal with it emotionally. And so that is an active area of interest as it relates to this topic specifically, and to the and I would say really all forms of aortic disease, whether it's after an event or even just processing the diagnosis. But it hasn't really been a specific focus thus far, but that's something that we hope to change in the future.
Excellent.
Thank you. Well, I was just going to say that we did actually have a lot of questions that we did not get to. So maybe I can get you some of these questions, and we can post some answers for these more specific type of questions maybe on our chat. group, and then maybe we can just do this again. I mean, I'm sure that a lot of people would really enjoy to hear more, and we just need to do some more Q&As. And thank you so much for doing this with us.
Yeah, delighted to. Thanks,
Thank
everyone.
you all.
Thanks,
Good night.
everyone.
Have a good night, everybody.
Good night.